Sir, good evening.
Good evening, Somnath ji. Good evening.
Sir, will you please try, is it sharing or not? If it is not, so I will share from my side.
Okay, I am just sharing right now. Is it visible? The slides are visible.
Yes, sir. Is it visible? It is clearly visible, sir.
And just see whether the slides are moving or not. I will just
Okay, sir.
put on slideshow right now.
Hmm.
Mm,
Yes, sir. It's perfectly moving.
Moving fine, no? Okay.
Yes, yes, yes.
Okay, I hope there should not be a problem. In case any problem arises, so you take over the slides from your
Okay.
side.
Okay, sir. Is there any technical, anyone from technical team?
Yes, sir. We will just 4 minutes are left. You can start directly at 7 p.m., sir. Okay.
Okay, okay. Sir, just 4 minutes left. Actually, we should start from 7 p.m.
Somnath, but there is no audience present.
No, 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 sir. 1 minute.
Sir, the other audience is from the different link. Right now, we are just only 3 people. We will be there in the meeting.
Okay,
The participants are watching from the another link, so they
okay,
won't be here.
The link you are joining in, sir, is it? It is for only speaker link, sir,
okay,
where
okay,
you are joining. So you
okay,
can't see the audience in your link, sir.
okay, okay. Thank you.
Sir, already 6 to 7 audience have joined.
Okay, fine.
Yes, sir. We are live now. We can start the session.
Sir, good evening, sir. So,
Good evening,
so,
Somnath.
so first of all, I warmly welcome Dr. Y.K. Singh for Thank you, sir, for joining our digital CME forum, and thank you for your valuable time you have given us. And I also welcome all the delegates who have joining in and who have also already joined in. So, sir, with your permission, we can start now.
Right, Somnath. Let's start the meeting.
Yeah.
So, uh, good evening to everyone. I will just switch off my video right now and switch on the slideshow. Right. So, the topic for discussion today is telmisartan plus amlodipine as the preferred initial combination in newly diagnosed Indian patients with hypertension. So, whether this combination is the preferred combination that is being used right now, and should it be continued with the same combination should be the preferred combination for treatment of hypertension patients in Indian scenario. Should it be the same that should be continued? Let's go through it and let's try to gain some knowledge regarding these two drugs and the combination therapy in hypertension through today's talk. So just before we start the topic, I would like to just put one question to everyone, and participants can just answer the question or put in a suggestion on the right in the chat box. So the question that I want to put is that what do everyone think that what is the percentage of patients who are hypertensive? They have control of their BP with antihypertensive medications in Indian scenario. So, how many patients do you think are controlled with treatment with hypertension? Just tell, anyone can interested can answer the question or put write the answer in the chat box. Somnath, you please check the chat box if there is some anyone answering the question.
Again, sir, the question. I think, sir, hello, sir, can you hear me? Am I audible? Sir, am I audible?
Yes, Somnath, you are audible. Just has anyone put in an answer in the chat box?
Sir, I think till now not yet. Sir, can you please repeat the question once again, sir?
So the question that I am asking is that what the doctors think that in their practice uh, is the percentage of patients who are hypertensive and are given drugs for hypertension. How many of those patients are under controlled hypertension? That with medicine their BP gets controlled in real Indian scenario. What is the expected percentage? Say 50% or 90%? What percentage of patients they think that are controlled and they have control of their hypertension with medication? I think there is no reply in the chat box. In any case, let's begin. So the answer to this question, we'll look into the slides. It's there in the first slide itself, and it is very dismal actually. So just to put in the perspective of the real world practice that is present prevalent in Indian scenario, that is important. That gives that what is the idea about the problem that is being faced by the population and how much changes can be made by starting the treatment. So let's proceed with the next slide.
One answer from Dr. A. Sarkar is doctor is saying 70% of the total population.
Okay, okay, okay. So let's look at the problem of hypertension in India. So according to the ICMR India Diab 17 study, the prevalence of hypertension is 35%, which is quite huge. and it is around 40% in the urban population, which is more than the rural population. And so, and this data was collected in a patient group of 20 years or older, and that suggests that almost 35% of the adult population is suffering from hypertension in Indian scenario. And this burden is gradually increasing with time. And also, this National Non-Communicable Disease Monitoring Survey, NCD Monitoring Survey, has shown that only 12% are controlled hypertension. So the answer lies here that the situation is really very dismal and very pathetic. It is only 12% of the patients have their hypertension in control in the present scenario in India. So, what is the difference of the hypertension in Indian patients compared to the Western population? Mainly, few important points that it is earlier in onset compared to the Western population and thus causes higher hypertension-mediated end organ damages. And also, since the incidence is rising and the control is poor, there lies a big opportunity with the physicians to treat those hypertensive patients and prevent the hypertension-mediated organ damages in these patients. What is the latest recommendation to be used and antihypertensive classes that is to be used? So basically, there are four classes of antihypertensive drugs that have been traditionally accepted as first-line medications for treatment of hypertension. One being the RAS inhibitors, which include the ACE inhibitors and the ARBs. The other being second being the calcium channel blockers. Third being the diuretics, and fourth being the beta blockers. But recently, beta blockers have fallen out of favor because of their modest decrease in hypertension and also the side effects that are there with beta blockers. And also, there is some evidences that not much improvement in end organ mediated damage with control of hypertension with beta blockers if they are given. Like so to say, most evidences disfavoring beta blocker use is in the patients with reversion of left ventricular hypertrophy with beta blockers. So the evidence is not that good, and also for prevention of stroke with control of hypertension, beta blockers are also not preferred choice for antihypertension in stroke patients because they have not shown to decrease the incidence of stroke. So that's why they are not in the first line preferred choices at present. And at present, instead of A, B, C, D as a mnemonic that can be used for these four classes of drugs, we are rather the present world over societies of hypertension and cardiology and various other societies prefer three classes of drugs as first line choice. That is ACD, that is ACE inhibitors or ARBs as one group, calcium channel blockers, and the diuretics. Either of these drugs are preferred as first line therapy. And in case the pressure is not getting controlled, then combination of these three drugs, two medications from either of these three group of drugs can be used. So there are actually three combinations that can be used as second line treatment if the hypertension is not getting controlled with a single medication. So it could be ACE inhibitors or ARBs with calcium channel blocker or with diuretic, or third combination could be calcium channel blocker along with the diuretic. So again, the preference for this combination is not given preferred by one particular combination is not preferred by any of the guidelines compared to the other combinations, mainly because head-to-head trials between these combinations are lacking, and thus most of these recommendations are based on consensus or an expert opinion. So and the limited data that is available that shows irrespective of the class of drugs or the combination of drugs used, the BP lowering effect is almost the similar. So either of these three combinations can be used. And in case the blood pressure is not getting controlled with two combinations of these three medications, then all the three medications have to be used. And in spite of that, if the BP is not getting controlled, then it is termed as resistant hypertension. That means if the BP is not getting controlled with ACE inhibitors or ARB plus calcium channel blockers plus diuretics, all these three medications have been given to a patient and the blood pressure is not getting controlled, then the patient is termed as resistant hypertension and requires other medications And most preferred fourth line medications in this group of patients is spironolactone, based on mainly the pathway 2 trial, which has shown greater beneficial effect with spironolactone. So compared to a beta blocker, so their spironolactone is the fourth line medication that can be used in resistant hypertension patients. And in any of these steps, you can use a beta blocker if there is a compelling evidence for use of beta blockers, especially in patients who have cardiovascular diseases or have heart failure, in which there is a pressing indication for using a beta blocker. There, beta blocker can be added in any of these steps. And in spite of these all four medications, if the BP is not getting controlled, then you have options of using an alpha blocker or a vasodilator or even a central sympathetic blockers that can be used. And the newer medications that have come up that can also be tried, though the evidence for their use in clinical practice, and there is limited uh, use in clinical practice at present. So this is the strategy that is being advised by almost all the leading guidelines on bodies that are present all over the world, including the Indian hypertension guidelines. So it is a repetition of the same thing. So let's skip this slide. Now coming to the topic of discussion today, which is the telmisartan plus amlodipine as the preferred initial combination. So there was an expert consensus statement published in 2023, and it was headed by Dr. Jamshed Dalal, and it had included 100 eminent physicians from all over India, and they deliberated over four questions, and uh, based on the deliberations and the consensus were made on based on Delphi method, in which almost if there was an agreement on 70% agreement on a statement, then it was considered a true or a preferred choice, and it was taken up as a consensus statement by these expert panels. And the four expert consensus statements that had been issued in this article will be the concluding slides of this presentation. And among them, one of these was that yes, telmisartan and amlodipine is the preferred initial combination for newly diagnosed hypertension in Indian patients. This was based on a consensus statement. So you have to understand that it is not a randomized trial; it is based on expert consensus. Majority of patients who are newly diagnosed in India may require initial combination therapy. This is because if we see, this is a nationwide cohort study which was done, and it showed that almost 70% of the patients are actually in stage 1, 2, or 3 group of hypertension, and most of these patients, which is roughly comprising around 70% of the patients, they do not have a control of their blood pressure with a single antihypertensive. That is a true fact. Almost it is said that if almost 70% of the patients do not have a control of their BP with single antihypertensives, and they will require a second antihypertension medication to control their BP. Especially as we go higher on the stages of hypertension, we will require multiple combinations to control the BP. And we will also try to learn why is it so during the course of this deliberation. So this is the data that almost 70% patients will require a combination therapy to control their blood pressure. Now, this was a Mumbai cohort study, and in which it was shown that stage 1 and stage 2 hypertension comprised around 50 to 55% of the population, and this was the outcome of patients with blood pressure. It showed that the patients who were in stage 1 hypertension, they had an adverse outcome of around 33% more risk of cardiovascular events compared to the patients who were either in pre-hypertension stage or had a normal blood pressure. And when you compare stage 2 hypertension, those patients had a higher chances of all-cause death also, which was almost 40% higher hazard risk as compared to a person who was either normal hypertensive or a pre-hypertensive. So you can see how hypertension has uh, a clinical role in preventing death also. So the treatment of these patients is very essential. This just highlights the importance of treating those patients. And as we go higher in the stages of hypertension, not only the death but also the end organ damages incidence, be it the heart, stroke, or the kidneys, CKD prevalences, those also increases with the stages of hypertension. Uh, now, this is the age-wise prevalence of hypertension, and it shows that almost 45% of the male population and 57% of female population in the Mumbai cohort study had hypertension. And this Great Indian Blood Pressure study, it showed that the prevalence was around 74%. Now, this could be a little bit confusing when we look at the data of an initial slide, the first slide that we showed, and there we said that the prevalence of hypertension is around 35% based on the ICMR in the 17 study. Now, here we are saying that it is around 50% or 74%. This is all based on the number of patients taken, the age group, and the main problem is with the age group. Like the ICMR study had, as I have mentioned previously, they had taken patients beyond 20 years. Now the Mumbai cohort study had taken patients mostly in the age group of more than 45 years, and this Indian diab study had taken patients of more than 55 years. So you can see that the prevalence is rising with age. So that is a known fact also, that as the patient's population ages, the prevalence of hypertension increases. So it is just a marker of that only. So just remembering one data, that is 35% prevalence all over India in all population age group is sufficient. So that gives an idea of the burden of the disease to us. So the mean BP that is at diagnosis in Indian patients is around 147 in patients who are already a known hypertensive, and the newly diagnosed patients have a systolic BP of around 150 millimeters of mercury. This is not very high, as you can see. It is just around 10 millimeters of mercury higher than the normal threshold for diagnosis of hypertension. And if we see the percentage of patients who are on combination therapy, it is around 33% in patients who are already known hypertensive, and in newly diagnosed, the combination therapy is being used in around 56%. So it is 33% versus almost 60%. So more patients are being put on combination therapy compared to the older patients who are already diagnosed in hypertension, and this is according to the recent guidelines that are being advocated for the use of combination therapy as first line treatment or as a initial treatment choice for hypertensive patients. Based on those guidelines, the prevalence and the practices of the physicians in India is also changing, and roughly 56, almost 60% of patients are being started on combination therapy as at the time of diagnosis. Now, this is regarding the use of medications in stage 2 hypertension. They say that stage 2 hypertension is systolic BP greater than 140 and diastolic BP greater than 190. And here the combination therapy was used in 60%. And this is based on the record registry, which is showing that there is a shift in the practice that is being used by the physicians at present, and almost 60% are using as first line choice as combination therapy in the patients who are diagnosed as hypertension. This should not be confused with stage 2 hypertension in other guidelines, which says that the stage 2 hypertension is systolic BP greater than 160 and diastolic BP greater than 100. This classification of stage 2 hypertension greater than 140 and diastolic more than 190 is based on ACC-AHA classification of 2017, and that says stage 2 hypertension as this criteria. So in most of the major prevailing guidelines, it would be stage 1 hypertension, that is the newly diagnosed hypertension who require a medication for their hypertension, which is more than 140 by 90, and there almost 60% of the patients are being initiated on combination therapy. So which candidates should be preferred on initial combination therapy regardless of their um, um, patient profiles. One is if the patients are on stage 2 or stage 3 hypertension, or if they have evidence of end organ damage or proteinuria. Proteinuria also a marker of end organ damage itself, or there is renal impairment for whom ACE inhibitors or ARBs are unlikely to reduce BP to less than 130 by 85, uh, or the target BP is unlikely to be achieved with a single medication. So in those cases, combination therapy should be the choice of treatment in as first goal in the first step only. And the uncontrolled hypertension, as we had seen in the Indian scenario, it was roughly only 12% of the patients had their control of hypertension with medication. So almost 90% of patients had uncontrolled hypertension. And there are various reasons for it, including low efficacy of monotherapy and underuse of combination therapy. So I would like to highlight the first one, which is the low efficacy of monotherapy. Just to give you an idea regarding the efficacy of the antihypertensive medications, so there are four classes of medications broadly that we know of for first-line treatment. And so even if we take the three first-line medication, that is ACE inhibitors or ARV, CCBs and diuretics, if we are going to use any of these medications in patients who are newly diagnosed for hypertension, so the expected decrease, the average decrease in blood pressure is in systolic blood pressure is around only 9 millimeters of mercury. So if a patient, as we had seen previously in the slide, the newly diagnosed patients of hypertension in Indian scenario had an average BP of around 150 millimeters of mercury. So if that 150 millimeters of mercury patient is being given either of these first line medications as monotherapy, it is expected to decrease a BP of around 9 millimeters of mercury. So he or she will end up with a systolic BP of 141 millimeters of mercury as an average. So that is not the target blood pressure that is being achieved. So this is the limitation of the antihypertensive medication. The efficacy is poor. They have a low efficacy. So there is a reduction of around 9 millimeters in systolic BP or 5 millimeters of diastolic BP only with a single medication that we have at present available for us with standard doses that is being used. So there lies the importance of using combination therapy, and it is being underutilized at present. We have seen that only 60% are being given, and probably a higher percentage will require combination therapy to achieve their hypertension goals. So the initial combination therapy can be provided better outcomes in management of Indian patients with hypertension. Is it so? Let us see. So this was a matched cohort study which showed that the initial combination therapy reduces the risk of cardiovascular events in hypertensive therapy compared to patients who were later switched on to uh, double combination of medical antihypertensive medications in case their BP was not controlled with monotherapy. So starting with the combination therapy rather than gradually increasing from going from monotherapy to combination therapy, the outcome was poorer in patients who were gradually increased or titrated their medications rather than starting on a combination therapy. So let us look into some details regarding this study, then we can have a better idea. First of all, the limitation is the one that is being mentioned in the first line. That is, it was a retrospective study, not a prospective study, and it used an electronic medical chart which that was used. So there are many fallacies or entries are not well maintained in many of the electronic medical charts. Leave it aside. Still, the case study was a retrospective one, and the baseline BP was equal in both the groups. It was well matched, and the problem with this study was the combination. The combination therapy, the add-on therapy was added after a average time period of 13.5 months. That is, if a patient with diagnosed with hypertension and he started on antihypertensive single monotherapy medication, and in case the BP is not getting controlled and he or she requires an addition of other medications to control the BP, the average time to add that medication in this subgroup of patients was 13.5 months, which is more than a year. More than a year had elapsed before any other medication was added. So the delay in adding the therapy was much longer, and that could amount to the differences that we have seen. in the outcome of the patients in this study. So it was very poor. The prevailing guidelines say that you have to add medications within 1 to 3 months. So this was beyond 1 year, which is a great delay in up titrating the medication. So there was, if you see the here the combination therapy was better compared to add-on therapy in each of these respects, except for hospitalization for heart failure, acute MI, stroke, and overall also all the primary outcomes were met with combination therapy compared to add-on therapy. So one limitation, as I said, was that the initiation of the second medication, adding of the second medication was much delayed in this age group or in this patient. And also, if we see the time taken to reach the same level of blood pressure with add-on therapy. So you see in the chart here at zero baseline, uh, if we look at around 30 months, 30 months, you see both the charts converge and meet at around 30 months. So first, the above line is the darker line represents the patients who have started on combination therapy, and the lighter line is the patients who were initially started on monotherapy and gradually uptitrated their medication to combination therapy. And both these patients converged at around 30 months. So to gain the same amount of BP, the add-on therapy, they required additional 2.5 years to reach the same amount of blood pressure. So there was a delay in achieving those blood pressure that could result in the changes, a better outcome in the patients with combination therapy compared to the monotherapy initially. So overall, there was 11% CV risk reduction with combination therapy compared to patients who were started on monotherapy. And one important finding from this can be illustrated in this table, which is on the bottom right side. If you see combination therapy, when it was compared to monotherapy, uh, and the BP was controlled, either with monotherapy or combination therapy, the odds of getting adverse outcome was similar. There was no better outcome with combination therapy compared to monotherapy if the BP got controlled with either with monotherapy, single medication, or a combination therapy. But in case the patient who was requiring combination therapy and they were gradually up titrated from monotherapy to combined therapy and they required multiple medications for their control of BP, then only the adverse outcome was poorer in those group of the patient. This also highlights the delay. The delay in getting control in blood pressure was the reason why these patients were fared worse compared to the patients who were initially started on combination therapy. This also highlights the patient could be started initially on combination therapy to get an earlier control of their blood pressure, and also it could be advocated in patients who are unlikely to follow up very frequently. So you can start them better on combination therapy, and they are more likely to reach their target BP if they continue to take their medications at home, in spite even if they do not come to clinic for visit, rather than giving monotherapy where the chances of getting control is less than 30% mostly. So this also highlights the same thing, that the initial combination therapy was better, and this has been highlighted even given in this systemic review, which had shown that there was better outcome with initial combination therapy compared to monotherapy and gradual up titration. And here I would like to just focus on few points from this graph, which could make us understand some important points also. One is the difference in the on the see on the graph on the left hand side. It mentions difference is the mean systolic blood pressure. So if we are starting in a dual with dual therapy, and both the medications are started at low dose, low plus low, we are going to decrease the blood pressure compared to monotherapy by only 2.8 millimeters of mercury. There is additional 2.8 millimeters reduction only. In case we start with a standard dose combination for both the medications, which is the last line here, standard plus standard dose of dual therapy is started as combination therapy as first line, it decreases blood pressure by 7.5 millimeters of mercury compared to combination therapy only. So there is a decrease by only 7.5 millimeters of mercury. So if a patient is coming in stage 2 hypertension, that is more than 160 millimeters of mercury, even if we start with a standard dosing of two medications with combination therapy, he or she is unlikely to achieve a goal of less than 140 millimeters of mercury based on the data present here. So this also highlights the low efficacy of the antihypertensive medications that we have at home. And there are studies also showing that if we go beyond the standard dosing, very high, that if we go to higher doses of antihypertensive medications, that also does not decrease the BP markedly. There is a non-significant decrease in blood pressure if we go to higher dose compared to standard dose. That means if suppose we are talking about telmisartan, so the standard dose is around 40 millimeters of 40 milligrams. So if we try to if a patient is not getting his blood pressure controlled on 40 millimeters, 40 milligrams of telmisartan, and we think that okay, let's increase the dose to 80 milligrams of telmisartan, and that might control his BP. That is very unlikely that patient is going to get his BP controlled with 80 milligrams of telmisartan if it is not getting controlled with 40 milligrams. So better option is to add a second drug rather than increasing the dose to a higher dose. And also increasing to a higher dose that not only has a very less chance of decreasing the blood pressure, but it markedly increases the side effects of those drugs. So if we use a dual combination therapy, so it not only we have a higher chances the patient will have a control in blood pressure, but also the adverse effects of the drugs are also minimized by using combination. This is also highlighted here that if we use a free combination rather than using a single pill combination fares better compared to a free combination. I mean to say, suppose we are using telmisartan and amlodipine. So if we have a single pill combination, that is going to have a better outcome compared to if we give a prescribed telmisartan and amlodipine separately. Why is it so? So the therapeutic benefit should be the same because both the medications are being given in the same dose. There should not be an effect on the uh, based on the why the BP is not getting controlled with free combination. It is just because the pill burden increases. That means the patient has to take twice two pills either at a time or separated by some time. So that increases the pill burden, and the patients are likely to miss their doses if appeal burden increases. And so single pill combination are better, the compliance is better. So the better compliance leads to a better control in blood pressure. It is not because of the therapeutic benefit increases, it is just because that the compliance is better with a single pill. So now, if ARB and CCB can be considered as preferred initial choice in management of hypertension, can it be? So according to all the prevailing guidelines, you can use either of these two combinations. So you can use ACE inhibitors, ARBs with CCBs or diuretics. So most of the combinations that is being at present used is actually RAS inhibitors with a calcium channel blockers. This has been highlighted in almost all the prevailing guidelines. And if we look at the combination which is being preferred, here also ACE inhibitors with a diuretic or ARB with a diuretic or ACE inhibitor with CCB or ARB with CCB is the preferred choice, and a CCB with a diuretic is an acceptable choice. Again, if we look into the reason, why is it so that why using a RAS inhibitor with a CCB is preferred rather than using a CCB with a diuretic? One reason could be because both CCBs and diuretics, because of their vasodilatory effect and decrease in the volume, they are going to increase the renal angiotensin system and also activate the sympathetic nervous system, and that is going to hamper the control in their blood pressure. And also these two, that is the renal angiotensin system and the sympathetic overactivation, increases the chances of end organ damages also. So by combining either of these two medications with RAS inhibitors, they are going to RAS inhibitors. On the contrary, they decrease the not only the renal angiotensin system but also the sympathetic stimulation. That way, they counteract the bad effects of these CCBs or diuretics. That's why combining RAS blockers with the CCB or diuretic is preferred. And out of CCB and diuretic, many prefer CCBs. The reason being the simplicity of dosing. Most of the CCBs can be given as a single dose, and there is a huge clinical experience with the doctors that it is very safe, and they have been using day and night and for long durations also, and it is very well tolerated. Side effects are very less. It is very cheap. Generic medication formulations are also available for CCB. Same holds for diuretics also, but diuretics have additional side effects, especially in elderly population where they can cause volume depletion. Chances of pre-syncope or dizziness are higher with diuretics, and also the electrolyte disturbances, especially hyponatremia and hypokalemia, which lead to frequent hospitalization. So that limits the use of diuretics in this group of patients. So that's why CCBs are preferred compared to diuretics, and combining CCB with RAS blockers is an acceptable choice, and there is a rationale for this also. So ARB with CCB compared to other therapies, again, it has been compared with beta blockers and thiazides, and ARBs with or ACE inhibitors with calcium channel blockers have in hypertensive patients have better cardiovascular outcomes and are also cost effective compared to beta blockers combined with thiazides diuretics. This is because of the, again, we have seen the side, one being that the beta blockers have modest decrease in blood pressure, and the thiazides are, diuretics are associated with side effects that we have mentioned before. So, using a RAS blocker with calcium blockers should be, as in general concern, in general thinking, should be the preferred choice for as first line combination therapy. Then there are few compelling evidences where we have to use ARBs. So there are evidences for ARBs or ACE inhibitors for their use in post-MI heart failure, diabetic nephropathy, proteinuric patients, in CKD patients. Also, there are softer evidences for their use in LV hypertrophy, atrial fibrillation, and metabolic syndrome. Also, where they have beneficial effects by decreasing the atrial fibrillation chances. Also. So there are compelling evidences for use of ARBs or ACE inhibitors, and where ARBs stand out in compared to ACE inhibitors is probably the side effect profile. ACE inhibitors have a quite high frequency of side effects in the form of cough mainly, and also angioedema. So the chances are relatively lesser with ARBs, and so probably they are used more frequently compared to ACE inhibitors at present. Though ACE inhibitors, if you see in either of these above indication, that is heart failure, post-MI, CKD, they have equal evidences compared to ARBs for prevention and disease modifying effect, and also in life prolonging effect of these medications. ARBs and ACE inhibitors have almost equal effect in all these above subgroups. Probably ARBs just stand out based on their side effect profile. And for CCBs, you can use it in isolated systolic hypertension and also in anemia factories. LV hypertrophy is very much decreased with CCBs. There are evidences. There are few evidences that the CCBs can decrease atherosclerosis also, and probably in pregnancy, these are very well tolerated and very well studied, and these are almost first line medications. And in blacks, CCBs have fared better. Also, ARBs are also compared to ARBs, CCBs are preferred in black. So, telmisartan plus amlodipine can be considered as preferred, can it be preferred initial combination in management of newly diagnosed hypertension patients? So let us look at few evidences. So telmisartan has cardiovascular effect, protective effect. On-target study had shown that telmisartan had an equal this cardiovascular prevention compared to ramipril. And again, as I mentioned previously, telmisartan stood out based on the side effect profile, where the incidences of cough and angioedema were lesser compared to ramipril. though the effect in the cardiovascular outcomes and BP control was similar with either of these two medications. So the chances of discontinuing telmisartan compared to ACE inhibitor is lesser. So probably most clinicians prefer telmisartan, that is ARBs, compared to an ACE inhibitor. And the evidence for telmisartan in cardioprotection is undoubtedly decreases LV hypertrophy and atrial fibrillation also, and then decreases chances of mm, heart remodeling is there in MI and post-MI patients and also in heart failure patients. And also it is renoprotective. It has been studied in multiple trials, and this is a study from innovation trial which had shown a clear benefit in patients who were albuminuric or CKD patients. Telmisartan has renoprotective effect. In that case, ACE inhibitors or ARB, any of these medications have equal benefit for renoprotective effect. Mm. And then this was a study about amlodipine as a cardioprotection effect. This was a Camelot study in which the primary endpoint was cardiovascular events, and it was decreased by amlodipine compared to enalapril. The reason was not very well known, though the decrease in BP was equal in both the either of these medications, enalapril or amlodipine. This could be one of trial in which amlodipine fared good compared to enalapril. Otherwise, as we know, enalapril or ACE inhibitors are equally good cardioprotective effect, also probably much better than amlodipine. And mm, in this study, one important point was that IVAS also showed a decrease in atherosclerosis progression with amlodipine compared to enalapril. So again, the reason was unknown why it did so. It cannot be explained by based on the pathophysiological mechanism that we know at present of both these medications. So amlodipine has a better CV outcome compared to when compared to a diuretic. This was shown in the ACCOMPLISH trial. So these are two trials which are showing the evidences in favor of amlodipine, but there are other trials which have shown that like diuretics have fared better compared to a calcium channel blocker, like the ALHAT study, where the diuretics that was used was chlorthalidone, and it had shown a better cardioprotective effect compared to a calcium channel blocker. So these are studies which are showing some conflicting evidences, and that is why uh, guidelines are made, or an overall evidence is important rather than just focusing on one study. So uh, the probably one reason for that was given in this accomplished trial, the reason for differences between heart study and the accomplished study was the use of the diuretic that was used, like hydrochlorothiazide compared to chlorthalidone. That could be one reason, since chlorthalidone has a better BP control and it is longer acting one. So probably that could be one reason why calcium channel blocker fared better compared to hydrochlorothiazide in this uh, study. Overall, evidences are equal for all the medications. So there is in none of the guidelines if you see one drug is preferred over the other for just for pure hypertension. If there is other compelling evidences that we have seen previously, like heart failure or other where ACE inhibitors ARBs are compelled to be used. Other than that, for pure hypertension, you can use either of these medications. All are equally good. You have to just look into the profile of the patients, how much they are going, cost of the medications and side effect profile and the age of the patients. And that should be the guiding point for the choice of the antihypertensive that we are going to use. So you can here also it showed the same thing that amlodipine has a better CV outcome compared to hydrochlorothiazide. And this was the same in the diabetes subgroup of this study. Telmisartan with amlodipine, just as intuitively as we can see that single monotherapy is unlikely to control BP, and the combination therapy are going to decrease BP much more higher. As you can see here, in place of 6 millimeters decrease with monotherapy, there is almost 30 to 40, 15, 13 to 15 millimeters decrease in blood pressure with combination therapy. Still, you see there is a decrease of around uh, 15 millimeters mercury only with the combination therapy, you see. So, as I was saying, if patient if coming with a systolic BP of 160, And if we start with a combination therapy and we give them both at standard doses, we are going to reduce the BP2 by 15. So that would be around 145. So that is still uncontrolled, and the patient is most likely going to require a third medication for the control of the blood pressure. So this is important point I want to mention more frequently, because this tells us that what is the efficacy, how much the medications the patient might require for control of the blood pressure. So instead of using a monotherapy in those patients and wasting your time, it's better to start with the combination therapy on the first go only. And amlodipine telmisartan, as we know, amlodipine has a very high chances of pedal edema. Around 10% patients have pedal edema with amlodipine, and many of them require termination or decrease in the dose of therapy of dose of amlodipine. This combination of telmisartan with amlodipine had a very low chances of pedal edema, and this has been explained based on the fact that the CCBs just increase the arterial causes arterial vasodilation, and thus increases the capillary pressure, because there is no decrease in the venous pressure, and the venous pressure is still high. So there is extravasation of fluid from the capillary. And if we use a RAS inhibitor, which causes a venodilation also, thus the capillary pressure is lower, and the extravasation is lower, and thus the chances of edema is lower. So as we see, the combination therapy not only has a better control in blood pressure, the side effect profile or the side effects of this are also counteracted by the other medicines, and there is a synergistic effect of this medicine also. And these both medications provide renal protection, as we've seen previously. So the effectiveness for in Indian patients, what is the effectiveness for renal protection of amlodipine? And it is well known that yes, calcium blockers are also renal protective, and this is albuminuria, especially in hypertensive patients, because the main mechanism in hypertension for albuminuria or CKD progression is because per se because of hypertension, and that is causing driving the disease. And if we decrease the hypertension or control the hypertension with either of the first line medications, that is going to have a favorable outcome, not only in controlling the blood pressure but also in preventing the end organ damages. So it is intuitive, and medicine is also renoprotective in hypertensive patients. So this is the same thing which is highlights one more. This important here is about regarding the incidence of pedal edema with amlodipine versus cilnidipine. This was again done by Dr. Jamshed Dalal, and um, very surprisingly here, the amlodipine had a lower incidence of pedal edema compared to cilnidipine. And it is little bit confusing, and it is actually uh, mm, uh, counterintuitive, and it is against the evidence that is present, which shows that cilnidipine clearly has lower incidences of pedal edema compared to amlodipine. And in clinical practice scenario also, we have clearly seen that the chances of pedal edema is lesser with cilnidipine compared to amlodipine. The probable reason could be, again, the reason could be because of the trial design. Again, if you see, it was a retrospective study, and it was based on a electronic medical record. So again, there is limitation in this study, and it is not an hard evidence to suggest that yes, amlodipine has a lesser chances. Overall, if we see the evidences, cilnidipine has a lesser chances and better tolerated for pedal edema compared to amlodipine. And this shows the use of hypertensive medications in America, and if you, by cardiologists in India. And if you see for hypertension management, most of the cardiologists prefer calcium channel blockers in the form of amlodipine and ARBs in the form of telmisartan. It is the real world practice at present also. Both amlodipine and telmisartan are the preferred choices in most of the physicians, not only the cardiologists but most of the physicians in India, and also worldwide. Also, if you see, more than 50 to 60% of the physicians prefer using these medications. And the same thing is been highlighted here, that either of these calcium channel blockers, especially the dihydropyridine group of calcium channel blockers, are preferred for control of hypertension. And Amlodipine being preferred because of the low cost and also the easy dosing, single dosing is required. That's why amlodipine is preferred in most of the patients. The only limitation being the pudilidema, which is being counteracted by telmisartan. So now we reach the final consensus recommendation. As I had shown previously, also the where 100 experts from all over India had put on four consensus statements, and they had reached a consensus on these four things, which I would read out to you. First is that majority of the patients newly diagnosed with hypertension in India require initial combination drug therapy, and I hope I have highlighted the important points throughout the discussion, which highlights the reason why this is so and why many of the patients should be started on combination therapy as first go only. Second consensus statement was that the initial combination therapy can provide better outcomes in management of Indian patients with hypertension. Though I had highlighted many drawbacks of the study, still since the evidence is there that yes, combination therapy leads to better outcome, there are RCTs also available and there are systemic reviews and the meta-analysis available which suggest that yes, combination therapy should be the preferred choices for improving the outcomes also. Third statement that has reached the consensus was that ARBs plus calcium channel blockers can be considered as first-line initial combination in the management of hypertension. Not only that, combination therapy leads to better control in blood pressure. We have seen the synergistic effect and also the counteracting the side effect profile of each of these drugs by combining these medications and having a synergistic effect leads to these two medications being the preferred combination as first-line medication. And telmisartan plus amlodipine can be considered as preferred initial combination in the management of newly diagnosed Indian patients with hypertension. It is the prevailing practice at present, and many of these, as you can see, almost 80% concurred with this statement, and thus consensus was reached on this statement also. Thank you, and I would like to welcome questions on this topic and further clarification or any doubts if anyone has.
Thank you, sir, for the wonderful explanation and brief discussion for all the slides. Sir, we will wait for another 5 minutes if any question asked from our respected delegates.
Yes, yes, please look into the chat box and please inform me.
Yeah.
So one point I forgot to mention was that the combination therapy, um, one additional benefit is the cost. Cost is lower compared to this three medications combined. So if you are using a combination, a single pill combination, the cost is also decreased compared not only the pill burden, the bill burden, that is the cost is also decreased. That also leads to a better compliance with medications and better outcomes.
Sir, one question asked from Dr. A. Sarkar. Is there any difference in incidence of pedal edema you observe while using amlodipine, cilnidipine, or azilnidipine?
Yeah, clearly I have higher incidences of fidelidema with amlodipine. If I have fidelidema with amlodipine, I usually change over to cilnidipine. Rarely with azilidipine because the cost is very high and also the availability issue is there. So mostly I change over to cilnidipine and the chances of edema are lesser with cilnidipine or azilidipine compared to amlodipine. It is a real world practices like that only, and even the evidences if we go and search, as I said, it could be one of studies which have shown the incidences of fidelidema lower with amlodipine, but overall evidences clearly show that the chances of fidelidema are lesser with other dihydropyridine compared to amlodipine.
Thank you, sir. I think Dr. A. Sarkar has got his answer. And the another question is from Dr. P. Goswami. The question is, while choosing between CCBs for renal compromised patient, which one to be the which one to be considered amlodipine or cilnidipine?
Renal compromise patients, all the drugs and all the calcium channel blockers are equally effective. You can say they have equal benefits. There is some evidences which say that yes, cilnidipine can be preferred over amlodipine compared uh, uh, for CKD patients. The reasons given are that cilnidipine not only has calcium, it blocks the calcium channels on the blood vessels. That is, it has a vasodilator effect. But it also blocks the calcium channel blockers, which are the N-type calcium channels, which are present in the brain and the nerves. So it decreases the sympathetic outflow also. And by decreasing the sympathetic outflow, it decreases the chances of intraglomerular hypertension and podocyte injury, and thus decreases the chances of CKD progression. So it is one of the critical pathophysiological mechanism mentioned where cilnidipine has a preference over amlodipine in patients with CKD. But overall evidences, if you see, both the drugs are equally effective for reducing albuminuria and CKD progression at present. By mechanistic mechanism, yes, cilnidipine could be preferred, but evidences are lacking based on RCTs. And probably, if in future there are RCTs that can shed more light on this question, but at present, either of these two drugs can be present.
Okay, thank you, sir. I think Dr. P. Goswami is very much satisfied with the answer. Uh, sir, as of now, no more question I have seen here. So, sir, we can end it now. And thank you very much for your wonderful explanation of the slides. And thank you very much for connecting with us to our digital ACME forum, sir. Thank you very much, sir. And I think today's discussion will help the younger practitioner who have joined to our digital CME forum for their future practice. So thank you very much, Dr. Y.K. Subhash Singh. We will again connect, sir, for another some on other topics, sir. So thank you, sir. We can end
Thank
it now.
you. Thank you, Somnath, and thank you, Glenmark team. Thank you
Thank
for
you,
giving
sir.
us the opportunity.
Thank you very
Great.
much. Thank you.
Good night.
Yeah, okay, sir. So with the permission, we are ending.